Yes, doc.
All right, okay. So yeah, before we get to questions, so I said that it's always key to start your heparin with your warfarin, because warfarin takes about 3 to 5 days to start working. And then once you get to the 3 to 5 days and you're discharging your patients, patient just goes off the heparin and then goes home on the warfarin. Okay. It's always good to assess your patient INR, which I explained before the lecture. So it's always good to check the patient's prothrombin time and divide it by the prothrombin time on your reagent or the control prothrombin time. Okay. So if you do that and then you are getting a value of maybe 2 to 3, that is what we call the therapeutic range when you are dealing with a patient who has DVT-PE. We want the INR to be within 2 to 3. That is like the normal therapeutic range, okay, for our patients. If your therapeutic range or your INR is less than 2, then it means that your anticoagulation is not effective enough to increase the dose of your warfarin, okay? But if your INR is more than 3, then it means that you are over anticoagulating your patient to decrease the dose of the warfarin. So that is why INR is key. So usually before we get a standard warfarin dose for the patient, you start maybe 5 to 10, and then you ask the patient to do an INR. And if the patient does the INR and then it's good, it's between 2 to 3, you just leave the patient on that, okay? And then the patient comes back for a review later, you can assess the INR again. If you do your INR and you realize that, oh, it's more than 3, then it means you have to drop the dose down. If maybe you started 10, you have to drop down to maybe 7.5, okay? So basically that's how you assess your INR. Do you have any questions there? Please, do you have any questions there?
Yes, sir.
Yes, please.
Yes, mine is with the embolectomy. I want to know if it is done in Ghana. And then secondly, to when are you supposed to do it? Because a lot of physicians miss their P. By the time you realize the patient is dead. So I want to know about it.
Yeah. I know Kolibu cardio units, they do a lot of amazing stuff there. So because I know they put in the Nakava filters and all that. So yes, I'm sure, because we have very good cardiothoracic surgeons here. We even put in pacemakers and all that. So I'm sure, yes, we do embolectomies here. We have very good vascular surgeons as well. So yes, it's done in Ghana. As for the missing of the diagnosis, sometimes starts from the starting point. Maybe the patient presented to maybe a small facility or some private facility somewhere, and the clinician there felt that PE is too much of a bigger disease for the patient, so failed to add PE to the differentials. Okay, so that is the reason why. As for the time you do the embolectomy, once you do your CTP, and then as I said, you realize that there's a clot sitting there large enough that you think might take too much time, you have to work hand in hand with the cardiothoracic surgeons, the vascular surgeons, and then they'll take a decision on when to take the patient in. Sometimes the patient's condition might not be so good for you to take the patient to theater. If patients cannot withstand anesthesia, so at that point, you can't go and do an embolectomy for the patient. Madam, are you okay?
Okay, thank you.
You're welcome.
Please,
Yes.
can you please highlight on the vena cava filters and the use of the third stocking.
The third stockings. All right. So the vena cava filters, as I said, before blood gets to the right side of the heart, it has to go through the vena cava, right?
Yeah.
So what the vena cava filters do is that once you put them in the vena cava, they basically work towards to screen the blood that is getting towards the right side of the heart. So it's not like it prevents normal blood from getting to the right side of the heart, because it's like a mesh sort of, okay? It's like something with some form of thread. It looks like a spider web sort of. So once you have it there in the vena cava, blood will be able to flow past it and get to the heart. But in case a clot should break, the clot will get trapped there and then, because the clot is too big to go through the mesh. So it will get trapped there and then. And once you are giving your anticoagulation and all that, with time, the clot will dissolve, basically. Are you okay with that?
Yes, yes.
So it's just like a mesh. It's not like it prevents blood flow to the right side of the heart. No, it doesn't prevent blood flow, but it prevents the migration of the clots to the right side of the heart.
Okay, Doc, with the mesh, a quick follow-up. After the anticoagulants have been given and then maybe the clot dissolves, is the mesh taken off or is left in place?
Yeah, so that's a fantastic question. So most of the time we take it out, okay? Most of the time we take it out, sometimes like a month to 2 months. It should give you enough time, for you to give your patient anticoagulation and all that. But if you have a patient who has recurrent DVTs and all that, as we've talked about, there's sometimes you can have a permanent, how do you call it? Vena cava filters. Okay. So because sometimes you can't tell when a patient will form the clot, and that's why I give you a risk factor. You have a patient who has a coagulopathy, a clotting disease basically, and it tends to clot more. Okay, we have a patient who has a deficiency in maybe protein C, how do you call it? Protein S, antithrombin. These are basically enzymes that you need to break down clots, but the patient has a deficiency in that. Okay, so of course, as part of your investigations for DVTP, sometimes you have to look out for the cause. So if you have access to protein C, protein S, antithrombin labs, you have to do it. If it comes and then it's low, then it tells you that, oh, this is the reason why the patient is forming the clot. Okay, and once it's low, basically the patient is deficient. You can't do much about it. So you'd have to think ahead, and then when you put in a filter, there's no point taking it out. Okay, people have like metallic stents in their bones and all that, so you can, just put it there and then you have it there.
Okay, Doc, my last question with a follow-up with the mesh. Evans was trying to say that, a mesh is like a net, and obviously without the mesh, the amount of blood that will flow through that point at a particular point in time, can we be fair if we say it will reduce with the presence of the mesh?
The blood flow coming to the right side would reduce.
Yeah, can we, because there's the mesh there says like a sieve, and without the mesh, the amount of blood that will flow there, I just want to ask, can we be fair if we say it will probably reduce?
It will reduce venous return.
Yes.
Like whether it would reduce venous return. Oh, yes. No, it won't.
Okay.
No, it shouldn't reduce venous return. Okay. Right. Because the blood is like the fluid, right? So when you have like a mesh, you are doing your abenkwan and you have a mesh and you are pouring your palm. You are pouring your palm not over the sieve. It comes down with the same pressure. Eventually, it will go through. Okay, it will just sieve off the solid components, right? But then the liquid component that you need to return will get there. Okay. Okay.
Ishmael,
so
the third stocking.
Yes, you said a third stocking. So the third stocking, as I said, is like a stocking that usually the patient would wear. Okay. Sometimes we use third stockings as a prophylaxis to prevent a clot from forming. Okay. And once you put on the third stocking, we expect that constantly third stocking is going to be putting pressure there to prevent you from forming a clot. Okay. However, when the clot is already formed, then it becomes controversial because the clot has formed. So how are you going to wear third stockings over that area and all that? So it becomes a bit controversial, but clearly you use the third stockings to prevent, as the name suggests, thromboembolic deterrent stockings. Okay.
Thrombo what?
Thromboembolic.
Okay.
So the third is not somebody's name.
Oh, okay.
It's an abbreviation. Thromboembolic deterrent stockings. Okay. Do you get it?
Ishmael, your hands have been up for a long time. Your microphone is unmuted, so you can ask.
So is that thromboembolic what? The T.
Deterrent stockings.
Okay.
Yes.
All right, Ishmael, let's hear you.
Yeah, thank you very much. So thank you very much for this wonderful presentation. I would have wished this presentation will continue for many times because I've really enjoyed it. Thank you very much for that. Now my question is under the clinical features, you made mention of productive cough. And mostly when we say productive cough, meaning that there's somewhere chest infection, which is making you to produce that such cough. So I wanted to know, is it that when the thrombus form or the clot forms and get to the chest, does it cause an infection? And does the bacterial infection or any infection set in that to produce that cough? And then what is the color of that cough that you can able to do your proper
All right, so it's a very good question. Yes, a very good question. So productive cough will always relate it to an infection, but it's not always the case. If and a clear example is you have a patient who has a congestive cardiac failure, which we discussed the other time, and we said the patient will basically have fluid in the lungs. So when the patient coughs, the patient can cough out some of this fluid. So in this case, the patient doesn't have an infection, but because of the fluid congestion in the lungs, coughs and then brings out some form of fluid or phlegm or sputum. Okay, that's like similar to PE. Because now there's a blockage there and blood is unable to flow, there's a congestion in the lung. So you don't need an infection always to bring out a sputum when you cough. So these people would usually cough and then it's productive. It comes out with a sputum. The difference there is if the patient coughs and a cough is productive of what, you have to tell us, of yellowish sputum, then most likely it's an infection. But if you say, oh, the patient coughs and the cough is productive of maybe reddish sputum or blood-stained sputum, then we can say that, oh no, this might not be an infection or this may be an infection. Okay, so we've kept it at the back of our mind that productive cough means infection, but it's not always the case. But then if it's productive, you tell us the color of the sputum. If it's an infection, it will usually be yellowish and purulent and smelly. So we know that there's a bacterial infection there, there's some pus going on and all that. But then when you are dealing with PE, it will be productive, but then it won't be yellowish for you to say it's an infection. It will rather be blood stained. And that is why as part of the productive, there's also hemoptysis over there, which means blood stained sputum. Okay.
Thank you very much. I'm okay.
You're welcome.
Foster, do you have a question? Hello, Foster.
No, I don't have a question.
Okay.
All right, okay. So
some...
great.
Sir,
So
sir,
yes,
sir,
yes.
we didn't get a
Yes,
slide
please.
on the heart failure.
Oh, are you sure?
Yes.
All right. All right, okay. I'll send it to you right away.
Thank you.
Okay. So, Doc, last question. The mesh.
Yes, please.
The mesh.
Yeah.
It's a foreign body. Do we, at a point in time, do you do maintenance on it to clean it or anything of that sort?
All right.
You and your mesh.
This mesh.
So
the mesh.
This mesh matter.
Yeah, so just like other foreign bodies, even if you are dealing with something like a pacemaker and things,
yeah,
it would have its own lifespan. Okay.
Yes.
So sometimes it gets to some time, it gets to a period where, because you have pressure coming from the blood vessels hitting it and all that, sometimes you might have it moving out of position. Sometimes it will be due servicing where you'd have to change it.
Okay.
You get it?
Yes, Doc.
So of course, I agree with you. It gets to a point where you need to basically assess the mesh or the filter and then decide if, all right, okay, should we still keep that particular one in, or one side of it is bent, so let's go and then remove and then replace a new one. Okay. Yeah.
No more questions about the mesh.
Okay. All right. So, God willing, on Sunday we'll take the cardiac arrest presentation. If we're able to finish on time, we'll do arrhythmias as well, and then we'll be left with the acute coronary syndrome. We'll try and finish that. Yeah, we'll try and finish that next week too, and then we'll start with some respiratory topics. Okay. Right. We're supposed to do cardio, respiratory, GIT, and then talk about some hematology, sickle cell, and all that before our exams. So I'm hoping we are able to finish that before April, so we can have the revision.
The Zoom will help.
Oh, once you make time,
we can do it on Zoom.
Yes. Once you make time, and I mean, I'm not on duty. Sometimes if you find yourself in class and weekend class and your lecturer is not in, and then, I mean, you hit me up to find out and I'm also not working, we can quickly have a 45 minutes discussion of the slides. They have created them, so it should be easy to discuss any topic you are ready to discuss. Okay, so I always be on standby.
Okay.
Thank you very much. Have a great day.
Thank you very much, Doc.
Yes. Thank you very much.
Okay. Good night.
All right. Bye.
Okay.
Good night.
Bye.
Bye.
Good night.
Good night.
Good.